Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
This edition of Conference Highlights is called Lessons on Epoch in the UK. It's presented by Carol Peden, Professor of Anesthesiology and Executive Director of the Centre for Health System Innovation, University of Southern California, University of Bath, and the Institute for Healthcare Improvement. Have a listen.
Okay, good afternoon, everybody. Can everybody hear me? I don't know if you can hear me in Australia, but I hope so. And thank you to the EBPOM team for inviting me. I've spoken at EBPOM in London a number of times, and I promise you they're not paying me to say this, but going to London in July it's a great meeting, and it's very sociable, and I would highly recommend it. So I'm going to talk about the Epoch Trial, which I'm guessing most of you in the room haven't heard of. It's going to be published. The main trial paper will be out in the Lancet in the next few weeks. We've published a couple of papers already about the implementation science aspects of it, and there will be more to follow. From a US perspective, I'm going to do a bit of translation because I am a Britican. Even though I'm British, I live in Los Angeles now, so I can speak both languages. So this is an NIHR UK-funded study, which was equivalent to the NIH here. And it's very serious approach to doing a randomized controlled trial for quality improvement. And already you'll understand that brings in some challenges because quality improvement is very context dependent, and randomized controlled trials try to remove aspects of context. I'm just going to thank these people who are very key to delivering this project. And I think these are the objectives I was asked to give. I hope you will have an understanding of what this trial was about at the end. It was a big trial, and again, a bit of translation. When it says 93 hospitals, I do understand that there's probably 93 hospitals in Dallas. Obviously, some very important and major ones, but in the UK, there are very fewer small community hospitals. And if you have emergency surgery, you will only go to big centres. And so these 93 hospitals were more than half of the hospitals that would do emergency surgery in the UK. So more than half of the major hospitals in the UK participated in this study. I'm going to talk a little bit about ethnography, which I'll explain later, and consider why. I want you to think about why some teams or what the challenges would be on improving this complex care. So the background of this study is that this was done for high-risk patients, and amongst the highest-risk surgical patients are those undergoing emergency general surgery. Not trauma and not vascular, but people coming in with acute abdomens. And there's various papers, and we've summarized the data in this paper at the bottom. But in the American data, about 11% of surgical patients account for 47% of the deaths. And in the UK, it's about 12 and 80%. But basically, the message is a small number of surgical patients, and those are generally emergency general surgical patients, account for a very large majority of deaths. So if you want to improve care and make things better, this is a group to look at. Now, at the time we were conceiving this study, the UK mortality was about 15% at 30 days. The Danish cohort studies, and they have really good data, theirs was 19%, 18.9%. And this is a paper which looked at all emergency general surgical admissions across the UK using hospital episode statistics. And you can see what it shows is that there's some, I don't think the report is working, but down here, the clear dots are low mortality hospitals, and up at the top are high mortality hospitals for the same procedures. So when you see that kind of variation, it's not just about the patients are older, the patients are sicker, this isn't great news. Something is likely to be different. Huge variations in care, huge variations in management of the patient. So that's what we were trying to attempt to do with the Epoch trial, is to set out a pathway that would be standardized and to improve this really high-risk patient care. So in case you're thinking, well, these Brits and these Europeans are crap at this, we're amazing in America. This was at exactly the same time as we showed 14% mortality in the UK. This is an NSKIP database paper from 37,000 patients in the US with exactly the same mortality that we showed in the UK. So this is a global problem. And actually, the database that we formed in the UK, the NELA, National Emergency Laparotomy Audit Database, has now been taken up by Australia and New Zealand to tackle this problem. Again, more US data. This is from Zara Cooper at Harvard, looking at Medicare discharges. And, you know, if you were 85 years and older and you had an emergency laparotomy or emergency general surgery, 50% of those patients are dead at 1 year. So this is not a British European problem, it's a pan-world problem. So on that background, we conceived the study, Epoch. This small percentage of patients accounts for a lot of surgical deaths. An emergency laparotomy, which we focused on in this study, is typical of that. The patient care is highly variable, survival is very variable, and that maybe if we took a quality improvement approach with a standardized pathway, we could make things better. Awareness of the issue is also a big problem. How many of you here in this room have pathways in place for emergency laparotomy or emergency cholecystectomy, major emergency surgical pathways? Okay, 3 people. So it's, you know, awareness, and this is coming because as part of the Johns Hopkins AHRQ grant on ERAS, the final year, next year, is going to be emergency general surgery. So what we did, the Royal College of Surgeons in the UK, on the background of this high death rate, had taken not an evidence-based pathway, because again, another problem in this field was there wasn't much evidence, but a Delphi consensus pathway. And we basically took that pathway, which was shown in this paper on the right, and devised a really complex pathway, which I'll show you in a minute. We wanted to create local champions, a lot of awareness about the issues, and give some basic quality improvement training, and then support the teams over the period of the study to see if they could improve care. If you're interested in that document, we've just redone it. If you go to the higher risk surgical patient, Royal College of Anaesthetists, we've just redone it 2018, and it's a really, I'm biased because I'm on it, but it's a really good document with a lot of key references. So go and have a look. On the background of this study, and I won't dwell on this, we had also at the same time, and it's actually important, at the same time as this study started, we developed this national audit, which was compulsory for all hospitals in the UK to enter data on these patients. And that's important because what we found later in the study was a lot of teams were struggling to see how they would enter data for this audit rather than then do the quality improvement. But that started in December 2013, and this study is actually fully launched March 2014. So the things we're trying to do was have a hardcore pathway that you were going to deliver. And if you think about this, when you see the pathway, you're going to be shocked in a minute because it's complicated. But that's really what we do when we get guidelines from a college or an association or care pathways. We put these complicated pathways in. We say to people, right, here you go, here's a bit of education and training, off you go and do it. So we wanted to support that with quality improvement, building a quality improvement team, helping teams to understand how they would use this data, teach them to do basic quality improvement cycles, testing change with PDSA, and breaking the pathway up into small chunks. This is the pathway. So complicated. But if you think about it, there's 37 steps, which is about the same as is in an ERAS pathway, 37 components, and it's very close to an ERAS pathway, and pre, intra, and post-op. And I can give you all the references, and I'm tweeting the references, so you can see them later. But we encourage teams to focus on these key points, which are in grey, on the pathway. So complicated pathway. These are the hospitals. I spent an awful lot of time on train, travelling around the UK, visiting various places. So this was going to be a stepped wedge cluster randomized controlled trial, which is really one of the few ways you can do a quality improvement trial, very scientifically. We had integrated ethnography, and ethnography is like anthropology. of clinical medicine. It's like having David Attenborough at the back of your operating theatre watching what you're doing. Going to capture the data through the national audit. The aim was to recruit 27,000 patients. That's what we expected to get from our background data. And the primary outcome was 90-day mortality. And that was powered to reduce mortality at 90 days, which we knew from UK national statistics to be 25%, to reduce that to 22%. So this is the chart. And the problem with stepped wedge clustered randomized trials for quality improvement is if you started here, you were going to get 80 weeks of improvement time. But more than half the teams got 30 weeks or less, and some teams, there was a 5-week running period, so some teams only got 5 weeks. And for many of you, you'll know that's really hard to do improvement on. So we recruited less patients than we thought, but we still got nearly 16,000 or over 16,000 patients, 7,000 of whom got the quality improvement phase. And you can see that the average age was 68, and they mainly had intestinal obstruction. And those are the patients who often get sat on, waiting, or they can wait till tomorrow. And then one of the key aspects we emphasized in this program was that when the surgeon makes the decision to operate, the patient should be in the OR in less than 6 hours. And as I say, that's because these patients were often, they've been obstructed for a few days, they can wait till tomorrow. We wanted to create that urgency around this. So, did it work? Well, overall, no, there was no difference in the mortality in 90 days between the patients who received the quality improvement and those that did not. But something was going on in the background because we were powered by UK data, so high-quality data, to reduce the mortality from 25 to 22%, but the 90-day mortality was actually 16%. And I'll explain a little bit more about why that may be in the background. But essentially, I don't think you can underestimate the background, this national audit going on, the fact that Rupert Pierce, who ran this study with me, was very well respected. There was a lot of noise, if you like, discussion about this study, and people were really thinking about emergency laparotomy. No change in hospital stay either. So that's fine, but the important thing if you're doing a quality improvement trial like this is to dig deeper. Let's discover why it worked or why it didn't work. So we had a lot of evaluation going on in the background. We had a national level of evaluation of the program, and for each individual site we had some ethnography or a questionnaire. And what we were trying to find out was what worked, what didn't work, why, what have we learned, and what can I pass on to other people about what you should or should not do. So, because ethnography is very expensive and intensive, we only had 6 sites. We had 3 coming in at the beginning of the study and 3 more towards the end. But we had 216 hours of observation of the teams and 53 interviews, which were then deconstructed by the ethnography team, who were separate to the trial team, to look for themes. We also had a 37-item questionnaire for all the leads in each hospital, which would be nursing, anesthesia, surgery, intensive care, ideally. And we had an 86% response rate. And so what did it show? At a cluster level, because the hospitals met in groups of 6, we found that everybody liked the quality improvement aspect. They got the trial. Everybody was very invested in making care better for these patients. And we delivered the quality improvement. They got the training they expected. The problem was we couldn't necessarily get everybody in the room. We had good attendance on the first day, but by the second follow-up training time, attendance had dropped markedly. It was difficult to get the teams in a room together, and basically they really struggled for time. The leads got no time and no funding to undertake this study. Each hospital got £3,000 to help with things like iPads. But essentially we were asking people to do this on top of their day job. And so it's one lesson, I think, is when you think about rolling out an ERAS program or a complex pathway, who's going to do it and how are you going to help them? Another subsequent study, which I can talk to you about over dinner or whatever, is we had more, I would say, buy-in from chief executives. If you don't get the senior leadership brought into these programs to support the teams, it's also very hard. But it wasn't all, bad news. We looked at 10 processes of all those I showed you, 10 key processes in the 80 hospitals that had good data. So we had 800 processes we could look at. And in the time, nearly 300 of those improved. Things like goal-directed fluid therapy got better. And you can see, some things like getting a preoperative risk assessment was relatively easy to do. That improved from 55 to 66%. But interesting, things that are harder, things like decreasing time from decision to surgery from 5 to 4.3 hours, that's hard. And that shows that you were starting to get some system change buy-in at a hospital level. We found that teams did use the quality improvement methodology, and basically in our next paper coming, the more you used some of these quality improvement techniques, the more success you had with improving processes. So we could show a link. So if you had a bit of training, and these teams got 1.5 days training at the most, and then supported by a website and individual phone calls if they needed it. But from a quality improvement perspective, it was really light touch, and it was designed that way so that we could roll out to a lot of hospitals. Another problem was the data collection burden. So we didn't have any data collectors. We were expecting the nurses or the anesthesiologists to enter the data. And there's a lot of data, and the NELA, the National Audit, had just started. So teams were definitely coming to terms with how they would do the data entry and not the quality improvement. But we did see, in this paper, I never thought I would actually get something published in the sociology paper as an anesthesiologist, but actually, if you have time, this is actually a good read, this paper. And basically, it's the interviews from the teams. And what you saw was that people really valued the fact that there was a pathway. And they really valued that we did a formal risk assessment, which gave a number which could facilitate discussion about how sick these patients were. So in a situation of complexity, when you're operating at night on sick patients and it may not be your area of expertise, having a pathway to fall back on, people found really, really helpful. And that, I can say the patient's risk score is this, therefore the pathway says this patient should go to ICU, is much better than ringing up and saying, I think my patient should go to ICU. You have a formal number and a formal pathway. It created national energy. There was a lot of interest in this study, and there's subsequent studies that followed on from this. Just basically surgeons, everybody presenting, lots of energy, people talking about this. What happened in the background? Well, I showed you that our mortality, when we were thinking about this study, was 14.9%. It's now 9.5% in the UK. At 30 days. So what drove that? Well, I've shown you that we can't say the Epoch study drove it, but it was very front and foremost, and there's another study that I was part of, which just came out yesterday in JAMA Surgery, called the Emergency Laparotomy Collaborative, which followed on from Epoch. And so there was these huge studies going on around all the country, backed up by this national data. And some of this may just be the Hawthorne effect. We have to collect the data. We know that we're not doing very well. We're going to work hard at getting better. But it doesn't really matter. That's a lot more patients surviving than did before we started all this. So what does it all mean? Well, for running quality improvement programs in general, for you, having a protocol, a pathway is all very well. Oh, we're going to do education on ERAS. That doesn't achieve very much. You have to work out how you are going to enable the local teams to deliver that care. And we found in our interviews that the social nature of improvement was very important. The teams who were very well networked within their hospitals, so they were mates with the radiologists, they were mates with the emergency department, they were very good at socializing, were much more likely to do well. So get some of those people that like to go round and chat to everybody and get everybody involved. This shouldn't be some project that anesthesia is doing. This is a whole system project, or this type of thing, as is ERAS, that everybody needs to be involved with, feel part of, and it's really important, and it came out in this. Being part of a big study, an NIH study though, did give some of our quality improvement leads credibility to say, we have to do this, it's an NIH study. If you're going to do a quality improvement program, yes, we did a proper scientific study. It's not necessarily the best way to look at quality improvement because it's so context dependent. And if you're going to do a step wedge trial, you need a very long tail for those at the end of the step wedge. And really, many successful quality improvement programs select hospitals that are ready for change. And by nature of this, we just said, are you interested in doing this study? We didn't select anybody. So in summary, this was a really complex intervention in a really complex area. And delivering effective quality improvement needs resources, executive-level support, change management, and social skills, thinking about those social needs for change. But it did massively help change awareness in the UK, and it may have helped drive the overall improvement. We've got further studies to come. The Lancet one should be out soon. We've got one already in implementation science. We're going to do an in-depth dive into 3 sites who did really well and 3 who did not so well. I think lessons in the US is keep it simple. I would go for, and in fact, a subsequent study, we just went for a small number of components we were aiming to improve. And think about how you create that energy, that everybody wants to be a part of this and everybody's talking about it. Thank you.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. EBPOM.org is their website. That's EBPOM.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.